Let's get going today. Good afternoon, everybody. My name is Adam Berkowitz. I am the president and founder of Simpara. We're a benefit advisory firm based in St. Louis, Missouri, and we are really thrilled to have you all today. We have about 300 folks attending this afternoon, and we have a jam-packed agenda with some phenomenal folks across the healthcare system. But I want to first acknowledge my co-host, Bret Brummit, out of Dallas, Texas, president of Generous Benefits, and Josh Butler from the Texas Panhandle, Amarillo, president of Butler Benefits. We brought the Texas heat for everybody today. So really appreciate everybody's time. Again, everyone's on mute. We encourage you to use the Q&A feature in the Zoom app at the bottom to submit questions throughout. We will do a live Q&A at the very end of the summit today. And we're ready to kick things off. So to kind of set the stage, these are certainly uncertain times for employees. Now more than ever, employees are looking at their health plan, wondering what will happen if they get sick. And when we look at how much money has gone to healthcare, it's enormous. We're not seeing the same value in return though. And working Americans have experienced the cost shift. As premiums have gone up, the response has been higher deductibles, higher copays, higher premiums, all in the name of consumerism, or maybe what we call skin in the game, as if somehow magically making employees pay more will reverse the cost trend. And the reality is a very different story. Employees can no longer afford their deductibles. In fact, the #1 leading cause of bankruptcy in America is due to healthcare. And most of these people had health insurance. The truth is, and this is hopefully why you're all here today, is that healthcare is already fixed. Wise employers have figured out that by improving benefits, costs actually go down. And take this example of an employer based in St. Louis. They've already maxed out their deductible. It's a $5,000 HSA plan. Nothing's covered till their deductibles met. And yet they were still facing a crushing 37% increase on their health plan this year. And this is what their plan looks like today. We have examples of employers spending up to 50% less than everyone else while providing incredible healthcare, wonderful benefits, and that's what today is all about. If you think about healthcare being a $3.6 trillion economy, just eliminating the waste, nearly $1 trillion in waste, we can stimulate our economies, our local communities enormously. And that's what this is all about today. You're going to hear from 7 of the top doers in healthcare to show you the path forward. This is not idealism. These are things that are happening today across the country, whether you're a small employer, a large employer, public or private, urban or rural. We're going to show you the path forward. And to kick things off, I am pleased and it's a pleasure to introduce you to Dave Chase, co-founder of Health Rosetta. Dave leads the vision for Health Rosetta, which is to empower community-owned health plans. Health Rosetta's blueprint and the platform powers the health plans of your dreams. High quality, trustworthy, local, affordable healthcare that you thought had disappeared forever. From caregivers we know and trust. Through his best-selling books and The Resident on Fox, Chase serves as a consultant. Collateral Damage for the Extractive Era on Healthcare is highlighted, as well as the tremendous successes and the opportunities with Health Rosetta type health plans. His books, his writing, his TED Talk have reached over 10 million people, all designed to lead a grassroots movement to restore hope, health, well-being to our communities. Dave has received the Health Value Awards Lifetime Achievement for Health Benefits at the 2020 World Health Congress. I am pleased to introduce you all to Dave Chase. Pass the screen here.
I think he's me.
I think you have to stop sharing your screen, Adam.
You should be able to take control.
Oh, all right. That work? Okay. You able to see the full screen?
You're on.
All right. Good. Well, thanks for the introduction. I'll go ahead and jump in. We got a packed agenda, an amazing lineup. And you know, where I'll start is just getting at this issue that healthcare isn't expensive. What's expensive is profiteering and price gouging. If you take a county like where I live, about 250,000 people, my estimate is at least $1 billion out of that $2.5 billion that's ostensibly spent on healthcare is extracted out of our local economy. And what's more local than an interaction between a patient and a doctor? And so that's forms a little the backdrop for my thinking. And so what I want to do is dive in, give you some of the high-level tips on recession proofing your organization. I'm sure we're going to hear a lot more. And it spells out an acrostic local, so you can remember that. And so we'll start with the first letter, L. And this is really the key thing here is learning how to liberate yourself from the status quo. When you do that, you can have dramatic overall savings. And this is really the most important step. Most people have been led to believe that solving healthcare is like as difficult as solving Middle East peace. They'd like to solve that too, but it seems kind of hopeless and out of their control. And it's just not the case. We've seen hundreds of successes around the country directly, and there's thousands of them. Really, the only question is, how long will it take to mainstream this? And clearly there's some folks who would like to not mainstream this, but this is a movement that's really focused in on how do we mainstream this. And let me just define a little bit what I mean by community-owned health plans, because I define community in the broadest sense. It's really having that ownership mindset versus a renter mindset. Got a bunch of examples all over the country, really every corner, public, private, large, small, rural, and urban settings. We haven't found a place where these strategies haven't proven themselves, typically costing 20 to 40% less with superior benefits. The inclusion of things like primary care and greatly reduced or fully eliminated deductibles. And so I'll share a few highlights of each of these. These are published case studies, in my book, on our site. If you don't see them, just ask us. We'll get through those. So let's just dive into a few examples. Rosen Hotels, this is a focus of my TED Talk. Just amazing result, continues to be an amazing success story that rippled in their community despite a very challenging disease burden with their workforce. They spend 55% less per capita on health benefits, with the best benefits package I've ever heard of any company around. And really the only thing that makes them unique is they've just been doing it longer than anybody else. They've been doing it for, I think, close to 25 years. Cumulatively, when they benchmark against their competitors, they've cumulatively saved over $350 million. And really encourage you to dive into that story. It's an incredible human interest story. Another story, it's a union, pipe trades, about 16,000 members in Minnesota. And the remarkable thing is, even though they've only gotten 25% of their members into this primary care model, it's a really impressive primary care model, basically because 99% of their members are male, and women tend to make most of the household decisions. But despite only 25% of their members getting in and only doing primary care, and we know there's a lot more you can do, they haven't seen their overall healthcare costs go up in nearly a decade. So that's, another example. Or Pacific Steel, a manufacturer and recycler out of Great Falls, Montana, 9 employees in 9 states, 40 locations. Last year, they closed out at almost $5 million less than what they were spending. They were over $8 million 4 years ago. And while benefits improved, they took their spending less, to under $3.5 million. And again, amazing story. And for a low margin, relatively slow growing business, that kind of impact is really remarkable. And again, great case study. You can get more details on that. South Central Alaska, the only 2-time winner of the Malcolm Baldrige Award in the healthcare industry, again, built on a foundation of proper primary care. One of the things I love about this is they talk about their patients as customer owners. They really have that ownership mentality versus a lot of people have just kind of rented health plans. And when you consider that every CEO says employees are our most valuable asset, you know, why wouldn't you own that that decision? You know, another example, this is in rural Colorado, just east of Denver, and this is a school district, Bennett School District. They are spending 50% less than what they were spending before. And consequently, they're the only school district in Colorado to have actually given their teachers pay raises. The pay raises for teachers were stolen by the healthcare industry in all the rest of the state. So once again, built on the foundation of proper primary care and doing some of the other tactics that we'll talk about in a minute. But you see it happening all over the country. It's really these green sprouts. Of course, Adam and Bret and Josh, they're doing these things, but we really see it all over the country, and it's really dynamic to see what's going on. So then the next thing that I'll highlight is which is, you know, optimize the plan infrastructure. This is kind of the boring stuff, but what's notable is, yeah, you can get some savings here, but what it does is it impacts all the other things. And the thing that I should point out here is, as you go through these 5 steps, there's only one that really has a potential to negatively impact your members. All the others are either invisible or they're a positive. And on the one that has that potential, I'll talk about it, but you know, it doesn't have to be negative at all. Quite the contrary, as we've seen with organizations like Pacific Steel. But this is kind of the underpinnings, right? It's having the right advisor relationship. That's why the tip of the spear of our movement is working with properly aligned advisors. It's working with the right type of TPAs. It's having the right kind of control over what you're doing and give you the freedom to do what you do. Rather than a carrier controlled plan, you have an employer design plan that's really tailored to your particular needs. And so I think it's notable. If you look at, we actually have a case study we could share, a talk from one of our past summits. Copper State, you know, they didn't actually change anything about their plan. They just got at the underpinnings. They're about 1,000 life plan. They found $1 million in savings just kind of cleaning up the gunk in the traditional plan. And that's the type of thing, when you have the plan sponsor bill of rights that's on our site in the book, you've got a proper code of conduct, you've got the proper disclosure, that's what can happen. Again, completely invisible to the employees, so it's very readily done. The C in local is carve out PBM. You know, consider that big three PBMs are all in the Fortune 50. And not to let pharma off the hook, but there's not one pure pharma company in the Fortune 50. That tells you how many shenanigans are going on in this arena. And so it's really a very low-hanging fruit from a member perspective. They don't have to go to a different pharmacy. They've just got a better administrator. And you see organizations like Caterpillar, for over a dozen years, they haven't seen overall healthcare costs go up. And all they've done is gotten very smart, applied their supply chain expertise to the pharmacy procurement. Pacific Steel, which I mentioned earlier, about a quarter of that savings came from smart procurement. The state employee plan for New Jersey, they've cumulatively saved over 3 years about $2 billion just on their pharmacy. So that's the kind of low-hanging fruit that exists. Now, let's get into, you know, primary care. It's so foundational, a little bit like the underpinning. You can get a little bit of savings there, but really what it's about is impacting all the other savings, avoiding, you know, preventable hospitalizations and ER visits, and guiding people to the highest value care possible. And it's notable that this is the first thing that can impact members, but only positively. When people roll it out, they tend to make it as an option. And consider that there was a survey, a study that was done recently, asked Americans, do you have a relationship, a primary care relationship? 50% said no. The other 50% were asked whether they'd seen that PCP in the last 2 years or could name them. Half of them said no. So in other words, 75% of the people don't even have a relationship with primary care. So, for most people, it's a completely new value add. For the people who are in these fee-for-service kind of drive-by primary care, it's a very different experience. And you look at some of the plans that I highlighted earlier, as well as others, the pipe trades, the Rosen hotels. I've written about the city of Kirkland. I've got a great case study with one of our advisors, Carl Schuessler, with the Gasparilla Inn. They all have proper primary care at the foundation of their plan. And so let's wrap with this acrostic local with another L, which is leave behind value extracting PPO networks. The most read article I've ever written was the have PPO networks perpetrated the greatest heist in American history? Spoiler alert, the answer is yes. There's tremendous savings opportunities. And when you see properly designed plans like a Pacific Steel, once again, the effect is all positive, because you go to a member and you say, if you choose this facility, often the same doctor, we'll waive all the cost sharing and co-pays, and you won't get EOBs, all that nightmare in the status quo. That becomes very appealing. And that's where the big savings really rely. And, the irony here is, if you're a self-insured employer renting a network, you're basically paying for the privilege of wildly overpaying. And there's no reason, you need to do that. So that kind of, spells it out. Some of the examples, some of the case studies around moving past these PPO networks to what we call transparent open networks. Here's some examples. I won't go into the details, but they're there on the website in the books, and we can certainly make those available to you. If you sum up these, we have this blueprint. This is kind of how it breaks down. The blue items are kind of the underpinning of the plans, kind of this kind of savings you can get. The purple items are where you can get those savings. Again, these things are spelled out in the plan, but it's really notable, where we spend money versus what actually drives health outcomes. And that's part of what we're fixing, is we're very bloated in these things. There's a lot of over treatment, inappropriate treatment, just outright profiteering, fraud, all these things. We can fix that. And really our mission as an organization and our fundamental belief is there's more than enough money sloshing around in our system to not only provide world-class health benefits, but to free up money for these other things. We call this the Health Rosetta dividend. Rather than that dividend going to hedge funds, this dividend should go to the employees. It should go to the company, go to your community. And if you look at the health outcomes and you follow this blueprint, that right kind of primary care and all these other things, if this blueprint was in a pill, it would be the blockbuster drug of the century if you look at the health impacts. So it's really dramatic. The irony is the best way to slash healthcare costs is to improve benefits, and we see that time and again. So you can learn more at our website. You can get free downloads of the book. You can go to my TED Talk. We have some fantastic speakers here. So with that, I'm going to pass the baton back to Adam and the MC, and look forward to hearing the rest of the speakers. Thank you so much.
All right. Thank you, Dave. Now we get to introduce the most colorful panelist we have today, which is Al Lewis. We're going to get to do something really fun, which is between speakers, Al's going to be hosting a live quiz. So this is the interactive part of today's summit. Al Lewis is the CEO of Quizify, which teaches employee health literacy using a format best described as Jeopardy meets health education meets Comedy Central. The healthcare questions are reviewed by doctors at Harvard Medical School, carry the Harvard logo. For today, he was prepared a mix of COVID, health education, and benefit manager questions, which we will play between speakers. And prior to Quizify, Al's specialty was measuring wellness outcomes. Two of his outcomes measurement books have been trade bestsellers. He was named Healthcare Book of the Year in Forbes. And before getting into wellness in the 90s, he was a partner at Bain & Company. He taught economics and graduated with high distinction from Harvard College. He also holds a JD from Harvard Law School, but his only high distinction was being the highest score in their annual trivia contest. Al, take it away.
Thank you very much. Okay, we're going to just do a few questions using the polling feature now, and then again a little bit later, and then at the end there's going to be a take-home contest where you can win actual cash prizes. So with that, am I controlling the screen? I think you're going to control. Yeah, so that we're going to start out. You're just going to use your polling feature and answer this, this question from COVID, which is, what is the smallest source of transmission in grocery shopping? We all know grocery shopping is kind of hazardous. What is the smallest source? As between shopping cart, salad bar, self-checkout, and cashier checkout. Okay, start your engine, submit the questions. And speaking of questions, do we have anything that's come in that you'd like to mention? Adam?
I think, well, pardon me, stutter speak. Due to timing, Al, I think we'll do questions at the very end.
Oh, there. Okay, so now we're just waiting for the poll that should be out in a second. I'll fill the dead time a little by telling you this is the kind of question that you can find right online at Quizify, that you can ask your employees and they can learn a few things. And we should have the answers coming in. I think I have to hit something actually and submit.
I've got it. I've got it here. We've got 70% voted so far. We'll give everyone a few more seconds and then we'll go to the next one.
All right. So what does the survey say?
Oh, you want to share the results now?
Well, we'll share the popularity contest now, then we'll do the answers later.
All right, hold on. Share the results.
Okay, so it looks like checkout is slightly the winner, so keep that in mind when we come back to it a little bit later. Next question is?
All right.
What should you do if your kid has a cavity in a baby tooth? So this is now a general health and healthcare lifestyle question. Get it filled even though it would be very traumatic. Ask the dentist to spray magic juice, SDF, on it. Use general anesthesia so your kid is unaware of what's happening, or wait for the baby tooth to fall out.
Now, Al, you were on Jeopardy once, correct?
Well, the operative word there is once. Yeah, the guy who beat me ended up winning the Tournament of Champions. So, you know, bad draw. That's what they always say in trivia. So do we have
We've got about 65% voted. We're going to give a few more seconds here.
Okay.
I will end this one. Let's share the results.
Wait for the baby tooth to fall out is the dramatic winner. We'll see if the survey is actually correct in a minute, or a little bit later on. So then the final question in this little interim. According to the New England Journal of Medicine, Journal of American Medical Association, and Choosing Wisely, how often should most people in the working age population get checkups? This is not to say have a relationship with their primary, but actually get an annual checkup. A, annual checkups are specifically not recommended by those three organizations. B, every 5 years. C, twice in your 20s, 3 times in your 30s, 4 times in your 40s, etc. Or D, annually.
Here we go. Al, while people are answering this one, you've been quite critical of wellness programs. Even if they don't save money, do they at least improve health?
Generally speaking, the traditional so-called pry, poke, and prod programs where they screen you and stuff, and what you do is you go out and eat a whole lot before you get weighed the first time, and then you crash diet. No, they're actually quite bad for your health, and it's actually been proven. It's been admitted by the leaders of the wellness industry that oftentimes they're bad for your health. And I have a $3 million reward for anyone who wants to try to prove that they save money because they don't. All right, after that, this answer is going to be a letdown, whatever it is. So what did the survey say?
All right, let's share these results here.
annually wins. Okay, so we've got cashier and wait for the baby tooth to fall out annually. So we will come back. Now you got to stay till the end. We will come back and see what the actual answers are. And now I'll hand the talking stick over to you, Adam, to introduce the next speaker.
All right, I'm going to
Okay,
unmute
Al.
here. Go ahead, Josh.
Great. Al, thanks so much. Those are some interesting questions. And for those of you who haven't seen, the questions get a little bit more colorful as we go on. My name is Josh Butler. I'm the president of Butler Benefits and Consulting in Amarillo, Texas. And I'm very honored to introduce our next speaker, Dr. Ruchika Fernandopulle. I had the first opportunity to see Dr. Ruchika speak at our Health Rosetta Summit in Dallas. And so I can tell you, you're in for a treat, extremely excited. I also started to listen to more of his presentations after that summit. And I hope I'm not stealing anything from you in your presentation, Dr. Ruchika, but you have a quote that I wanted to share with the audience, and it really resonated with me. And I love this quote. And it's the biggest reason why we invited you here today is, here's his quote: "If you're not upsetting anyone, you're not innovating." And so you can't be afraid to upset people. And so that's really what brought us all together here today in this conversation. So it's a big privilege for me to introduce Dr. Ruchika Fernandopulle. He is a practicing physician and co-founder and CEO of Iora Health. That is a venture-backed national de novo primary care group based in Boston, Massachusetts. He was the first executive director of the Harvard Interfaculty Program for Health Systems Improvement and the managing director of the Clinical Initiative Center at that advisory board company. He is a member of the Albert Schweitzer, Ashoka, Aspen, and Salzburg Global Fellowships, and is the co-author and/or editor of several publications, including Healthcare Policy, which is a textbook for physicians and medical students, and Uninsured in America, Life and Death in the Land of Opportunity. He serves on the staff at Massachusetts General Hospital and the faculty of Harvard Medical School, and on the boards of Families USA and the Schwartz Center for Compassionate Care. He earned his bachelor's, his doctorate, and his master's in public policy from Harvard University, and he completed his clinical training at the University of Pennsylvania and the Massachusetts General Hospital. Ladies and gentlemen, Dr. Fernandopulle.
Great, thank you all very much. Hopefully you can see me okay, and it's great to be here. Thank you for having me. See if I can get the, do you guys know how I control the slides? What the, there you go. All right. All right, whoops. All right, well, welcome. So I want to talk about the middle of Dave's acronym, LOCAL, which is about creating primary care. So, I think an important part of thinking about how to create a recession-proof health plan is really making sure that your employees, people, patients, are actually getting the right sort of care. And what do I mean by that, right? So in some ways, in the end, what we have to do is do two things, right? We have to actually make sure that people get actually better care. I think we can change a lot of other things, but if you don't change how actual people get actual care, it's all a waste of time. So I think at the bottom line, as I think Dave very much pointed out, there's a ton of waste in the healthcare system. I think those of us who have been doing it a long time, every expert in the world thinks that amount is anywhere between 30% and maybe even 50% of what we do. And these are just a couple of categories. I think there are a lot of evidence that a lot of unnecessary interventions. We're doing things to people that they neither want nor need. Number two is that there's really predatory and opaque pricing, particularly on the commercial side, where the pricing is crazy and often opaque. And then third is that people are suboptimally healthy. We're actually, unfortunately, despite spending too much money on things that people don't need, we're not spending enough on things people do need, and the lack of investment in prevention and chronic disease management, and focusing on what drives health. So can someone advance the next slide, please? Yeah, I got it. Okay. So primary care is really important. And why is that, right? So I think it's incredibly well positioned to help people actually improve health. It helps you improve your health, do what we call actually improving the upstream, the things that actually matter to improving health, how you eat, how you exercise, stress, relationships, but also can help you navigate the system and coordinate with specialists, co-manage in the hospital, streamline the pharmacy. You know, I think there's a lot of efforts to give people high deductible plans and make it the consumer's problem. This is really complicated. There are huge power dynamics. You know, thinking that a poor employee or consumer can make these decisions themselves is just silly, right? I think primary care is a great lever done right to help people navigate the system. So, let's see if I can get this right. Whoop. So the problem, though, is typical primary care practices out there are not built to do this, right? They've turned into these transaction machines where they document, code, and bill. They move to the next patient. There are 7-minute visits. You know, I think when I went to primary care, I thought it was this picture on the left, which is the doctor looking at the patient, a relationship. And unfortunately, we built practices that look like this drawing that was in JAMA, right, of a little girl in the middle, you know, seeing her doctor with their mom, and the doctor turned off to the side, typing on the computer, trying to get their billing, right? And there's a great quote from a friend, Jonathan Bush here. The biggest problem with healthcare today is not the cost, but for all the money, it's not an expression of our humanity. So what we've done at IR Health is an example of a group of what I think Dave correctly called direct primary care practices. You said, what if we started over? What if we built a new primary care model that's actually built compatible with all the things that Dave was talking about, to build what I call advanced primary care, to be able to actually improve health, help people navigate the system. What does it look like? And I'll talk a little bit about what that is. So let's see if I can get to the next slide here. And really there are 4 things that we have to change, right? Got to change the payment, got to change the process, got to change the platform, and really change the culture. Let me talk about each of those quickly in turn. So the first is value-based payment, right? So the original sin of most primary care is fee-for-service, where they're paid per thing they do. Guess what happens when you do that? You get more stuff done to people, you know, as opposed to actually improving people's health. So we get paid what's called some version of a primary care case rate, maybe some shared savings, or even moving to full risk, value-based payment models. These are really important to help primary care practices do the right thing. And by the way, that's within your control as an employer of how you end up paying these practices. So we do this, next slide, whoever's controlling it. Appears not to be me, is the move to, you know, we do it a little retail, but really work with a number of employers, people like the Boeing Company, Unite Here, the Downtown Project in Las Vegas, Group Insurance Commissioner, which are the state employees in Massachusetts, et cetera. We also work with some Medicare Advantage plans for seniors. Most of the time, we contract directly with the employers. We sort of end around the health plans. The health plans are sort of, to be honest, get in the way, and they just sort of take their percentage off the top. Primary care is a predictable sort of thing, and why exactly are we letting the health plan stand in the middle of it? So we directly contract with their employers. Next. Oops. We're slowly advancing. There we go. So we then build a completely different process around it. So we built sort of small practices. We started building on-site practices for big employers, and now we work with what we call near-site practices. So in Phoenix, for instance, we have 12 practices across the valley, and we allow our customers to sort of let their people come into any of them. We build robust teams. So it's not just about the doctor, right? This is a picture of our team that we had in Las Vegas, which is working for the Casino Workers Union. And 2 of those people in the pictures in the top middle are doctors, but the rest of the people are people we call health coaches, or from the community, whose really job is to help the patient improve their health, engage, and navigate the system, right? They're picked for empathy, because that's the reason we engage people. We take people grocery shopping to help them figure out what to eat. You know, we do groups like chair yoga, the picture here. We all huddle around the table. We email and text them and video chat them. And by the way, particularly in this COVID era, that's absolutely the right thing to do. Only about 10% of our encounters right now are in person. It's important to see people in person to meet them. There are some encounters where you have to see people to do physical exams. There's some conversations that are best done in person, but everything else can be done using modern technology, text, email, video. And this is not new to us. We've been doing it since we started. It's the right way to see people. We're also proactive and not just reactive. If you think about most practices, they sit in their office and they wait for people to come in. That's a really stupid way to optimize the health of the population. What we ought to be doing is checking up on people and making sure they're actually doing the right thing. So next question. There we go. We built a different IT platform. I think a lot of you may have heard of Epic and all these sort of eClinical Works and other sort of electronic health records. Really, all of them are built, they're fancy cash registers. They're built to help you document, code, and bill higher, and not really to help you optimize the health of the population, not really to help you engage with the patient and their family, allowing patients to communicate with us, to send us messages, to send us data about themselves. So think about it. The way most doctors manage hypertension, which is very common, I'm sure, in a lot of your employees, is they make you come into the office every 3 months. They take one value in the office and they make decisions based on that. That's stupid, right? Who cares what your blood pressure is in the office? What we really ought to do is have you at home, take your blood pressure, send them to us regularly. If they're doing fine, we should tell you, keep doing what you're doing. If they're not doing fine, then we can communicate, again, using other forms of communication and change the plan, right? So really a very different way to manage health. Next. You know, and really, I think what we need to do is build very different cultures around what we're doing, right? And these are our values. These are little cubes that we have sitting around our practice: to feel empathy, bring creativity, serving with humility, acting with passion, demonstrating courage, right? So I think really when you rethink primary care from the ground up, as us and a number of other sort of direct primary care practices have done, we get out of the usual payment model. We can really do some pretty incredible things. The next slide. So we're around the country right now. You know, this is some of our locations, largely in the South and the West, a few in the Northeast. We have 48 practices. There are probably, you know, a few thousand direct primary care practices around the country. They vary from people like us who've got a number, and we've been sort of venture backed. I think there are others who are mom and pop practices that do this. But I think in almost any market that you're in, there's a small number of folks like us who are trying to recreate the model, and I think works very well in the context of this larger redesign of benefits, as Dave talked about. Next. So does it work, right? And absolutely. And by the way, Al, I'm sure if I don't, we'll say you've got to be really careful in how you evaluate these sorts of interventions. There's lots of how to lie with statistics 101 that people play on how to do it. The best way to do it that we have, apart from randomizing people, which is not going to happen, is using sort of propensity match controls and, you know, getting an independent academic to take people who come into their practices, match them to people who look as close as you can, and follow the two trends across. It's the way CMS evaluates the demonstration. This is work we did with Boeing in the Seattle area, which showed a 20% drop in total spend of our patients relative to the controls. Better physical functioning, better mental functioning, you know, better patient-rated care that they got it. And what's interesting is a huge drop, 50+% drop in absenteeism days, which is something that I think Boeing in particularly liked because they were at the time, you know, running at capacity. Next. This is data from the culinary union that we had in Las Vegas. Same thing, propensity matched control group. And what you see is inpatient admissions in the control group went up by 2% over the year, but dropped by 35% in our group, that 37% relative drop in admissions. That's a huge number, right? And we see this over and over again, the roughly 40% drop in hospital admits if you actually manage people better. And by the way, when you do admit people, when you do get procedures, we're also sending them to places that have reasonable pricing, which is another piece of it. And then the second piece here is the total cost up 7% in a year, which is sort of typical at the time in the control group, and down by 5%, even when you take into account the higher cost of primary care. So it's a 12% drop in total spending, right? 12% is a big number. By the way, we did this with the casino workers in Atlantic City. The way it worked is, you know, for Taft-Hartley Trust is the union was given total health care. They decided they were going to negotiate total compensation. And for 7 years, they couldn't give people raises because all of the compensation that they negotiated was going to healthcare costs. We built a practice like this for them, and for the first time in 7 years, they were able to put 50 cents an hour back in people's paychecks. So I think Dave Chase made a great point that what we need to be doing, healthcare is extractive, it's taking money out of our pockets. I think that's no longer acceptable. And I think by actually aggressively managing healthcare, by actually doing the right people and giving people more benefits and more care, but in the right way, you can actually reduce healthcare spend and put it back in their pockets, which is exactly what we need. This is just a note about COVID. I think it's hard to give a talk these days without thinking about how COVID's affecting this. As I think all of you know, the world has changed, right? And I think a lot of people now are less willing to come into a primary care practice or any medical practice, and they shouldn't, right? Because of being exposed. This is what happened to us. You notice this is every day our number of encounters go, and you know, it's about the same. The blue bars are our emails. The green bars are in-person visits, and the light blue bars on the top are phone calls and video visits. And we were going along, you know, you notice how many of our encounters were done virtually, either video, phone, or email. But then what happened, if you look at March 16th, when COVID hit, we very quickly went down to only 10% of encounters being in person, a huge jump in the number of encounters. And what were those? A huge jump in emails, but a huge jump in phone and video. And this was us reaching out and checking up on our patients, right? It is really important that we were checking up on them and making sure that they were doing the right things and staying away from exposures and the like. Our COVID rate is virtually zero among our patients because we were on top of it so quickly. Next. I think the real opportunity here, which we're working on, is really what I call building telemedicine 2.0. A lot of employers are going around and contract people like Teladoc and Babylon and Amwell to provide video visits to people. And those are all well and good. And they're sort of what I call video urgent care. I think that's sort of minorly interesting. But just like, you know, my kids are at home trying to do, you know, their school is, instead of doing real education, they're trying to do a few Zoom calls a week, and that's not real education. Similarly, I think these sort of folks are not real healthcare. What you need is really centered around a patient, not a disease, combining primary care relationships with this technology and enabling longitudinal primary care. And that's what really helps people navigate the system and do the right thing to improve their health. I think that's where we're going. So finally, just a few last thoughts. Employers have a huge role in all of this. It's a strategic issue. This is not just a benefits HR one. Yeah, Dave mentioned holding health plans accountable. There's so many employers we've worked with who say, oh, my health plan won't let me do this. And you say, like, come on, like, they work for you, not the other way around. You know, banding together in markets to increase power, you know, focusing on improving care, and primary care, I think, is a great place to start. This is supply chain management. I think the days of saying we're going to contract with every schmo with an MD in town are over, right? And I think you have to find high performers. I think we're them. There are lots of people, a lot out there in the market. You know, be willing to work with new entrants and then play the long game, right? I think a mistake a lot of people make if they think they can do this. You can do this fast, but I think you need to be willing to wait and be able to get employees to change behavior. And I think we and other people who've been doing this for a long time say that there are huge returns. So thank you very much. I look forward to questions at the end.
Adam? Am I on? Okay, so we had the first question. We had the first answer. And we can go to the answer. The answer is, you know, actually, I can't even see it right. Hang on a sec. The answer is a salad bar, because food has probably never transmitted a case. That may be an exaggeration, but food packaging has transmitted many. And if you do things like this on this is the exit to the supermarket where you can wash your hands or sanitize your hands. And then if you go to the next, am I controlling it? Or you're controlling? If you go to the next slide, this is what happens. You wash your hands and then you take the shopping cart and keep going with it. The handle of the shopping cart the virus lives a long time on that. And likewise, it lives a long time on food packaging. The gloves that the cashiers wear, gloves are so April. At this point, I think people know that the virus lives longer on gloves than it lives on your hands. And you're much more likely to touch your face with gloves than you would be with your hands. Next. Okay, so this one, we had vast majority of people say, wait for the baby tooth to fall out. And the correct answer is ask the dentist to spray magic juice on it. Next slide, please. Okay, this magic juice, it said in parentheses SDF. It's called silver diamine fluoride. It's FDA approved, it's painless. I had it put on my own teeth. It works like a charm, and the reason your dentist hasn't told you about it, very consistent with other things, is that it only costs about $25 or $30. It does not cost $100 to fix a cavity. The other slight disadvantage is that your cavity will turn black. So that's why it's good for kids whose teeth are going to fall out anyway. And for adults, I had it on molar. Nobody can see it, even if they could. I'm not trying to impress anybody anymore. I'm already married. But it's a winner. I mean, they use it all over the developed world, except in the United States. Okay, and now for our least popular question of all time, how often should you get a checkup? We had a lot of very close answers in here, annually one by a very small amount, but the answer is that none of these organizations recommend annual checkups, not JAMA, not Choosing Wisely, not the New England Journal of Medicine. So first thing I would ask is, next slide, please. Don't shoot me, I'm just the messenger. Okay, I'm just telling you what these guys said. The answer that, and here it is, you can look at it, Choosing Wisely. Oh, you can't quite read it there, but it says that healthy people often don't need checkups, and they actually just lead to more care. The New England Journal of Medicine has editorialized against them, and JAMA says health checks may be associated with more diagnoses and more drug treatment, which of course is exactly what we don't need. The answer that we prefer, next slide, is twice in your 20s, 3 times in your 30s, 4 times in your 40s, etc., which is the one that carries the seal in our answer set. Now, as I say, this is probably the question that people take out the most often because they want their employees to go annually. Somehow, if the earth revolves once around the sun, you need to go to the doctor. But let me tell you the absolute best answer of all, which is very consistent with what you've heard, is get a relationship with your primary care doctor and ask your primary care doctor when you should come in for your next physical. It should not be what Human Resources wants to do. It should not be that the government is giving it to you free, quote unquote free. It should be that if you require a form to prove that an employee's got a physical, there should be a line on that form that says schedule your next physical for 20 whatever. If it's somebody who's healthy, it might be 5 years. If it's somebody who's not healthy, it might be next year. So don't make employees get physicals their doctor says they don't need. This is the flip side of having a relationship with a primary care doctor, is they know not only when you do need care, but when you don't need care. I just got a question I can't answer, frankly. What if your PCP gets a payment modifier for annual physicals? I don't frankly even know what that means. It's a great question, and let's put that one in the so-called parking lot, and we'll send you the answer to that. I'm just talking from a clinical perspective here, that just as Rishika said, just as Dave Chase said, it's about having a relationship with your primary and getting the physicals that and getting the amount of care that your primary says you should get. Okay, I believe that's it. Back to you.
All right, thanks, Al. We appreciate that. Very intriguing information. Who would have thought that there's just a $25 magic syrup that you can pour on your, and I'll remember that trick next time my 9-year-old needs to go to the dentist and they want to do a bunch of cavities. Anyways, okay, next up is one of my favorite people, not just one in this industry, but in general. Marilyn Bartlett, many of you know, and if you know Marilyn, you know how tenacious and how relentless that she is. Many of you know her story, and she's going to share more of it about the state of Montana here. But I just wanted to say that her boldness has really inspired and motivated thousands of people across this country into action, into reforming our healthcare system. And I'm very honored and to introduce her today. She's a good friend of mine, and Marilyn earned a bachelor's degree in education from the University of Nevada, later achieving her CPA credentials. Shortly after that, Marilyn immediately turned to the business world, holding financial management positions in various industries. Her focus narrowed to healthcare financial management, and she served as the controller for Blue Cross Blue Shield of Montana, the CFO for a regional TPA, and special projects coordinator for the Montana Commissioner of Securities and Insurance. In late 2014, Marilyn took the helm of the Montana State Employee Health Plan, and she achieved significant plan financial improvements. I think that's an understatement, Marilyn, in their healthcare system there in Montana. And for her accomplishments, she appeared in an article co-published by the National Public Radio and ProPublica, and she was also selected number 13 of Fortune magazine's World's 50 Greatest Leaders of 2019. And she was most recently inducted into the Montana Business Hall of Fame. Marilyn currently is serving as a Senior Policy Fellow for the National Academy of State Policy, and she is engaged in healthcare consulting around the country. So everybody welcome my friend and colleague, Marilyn Bartlett.
Well, thank you very much. I really appreciate that introduction, Josh, and I hope I can live up to it. It's a pleasure working with this team that is doing the presentation today. I'm really glad to be a part of it, and hopefully I can share some information that's valuable too. Next slide, please. I think this is a time that there are many opportunities out there for employer health plans and for consultants. If we look at the headlines that have been running in the newspapers from these different, through this pandemic, we see a wide range from that are impacting employers, from shutdowns and layoffs to ensuring your employees are safe. But I particularly like the headlines that Sherm posted in the lower left-hand corner. And there was 2 articles. One said employer healthcare costs are expected to rise due to the coronavirus. The other said, no, there are options for lower prices. And I put this out there because I think it is a time that employers and consultants are in a position to really make some changes. Next slide. Most of you know the Montana story, but when I took over the health plan in late 2014, the actuarial projections showed that the plan reserves would be at -9 million in just 2 years if we did not do some drastic changes. So we did. What I'll be telling you today are the basic things we did, which follow exactly what our previous speakers have talked about. I followed that Health Rosetta model. And as a result, we ended up with 112 million in reserves in that span of time, to the point that we had more in reserves than the Montana General Fund. And the state was borrowing money from us for most of the summer of 2017. And then a special session was called, and in early 2018, a premium holiday was given to the employers so the state general fund could receive 25 million from the reserves. Next slide. So our goals were not to raise member contributions or out of pocket, not raise employer contributions or flatten or decrease costs. We had to flatten or decrease the costs, and we had to restore the reserves. So we did not want to push this off on the employees. We did not want to push it back on the legislature. We wanted to restore the reserves. And the only way to do that was to take money out of the healthcare system and at the same time improving the employee benefits, as our previous speakers have noted. So our strategy had 4 steps. Number 1 was primary care, which we've talked about. Secondly was hospital costs. Hospital costs are the largest portion of your health plan spend. For Montana, just the Montana health plan costs represented 43% of the total plan costs. Of that, 87% of that chunk was attributable to 11 acute care hospitals. The third phase was looking at PBM and RX benefits. We knew there'd be money to be saved there. And then I liked how Dave called it spring cleaning. We did look at our health plan, but we looked at the multitude of vendors we had to, and I strongly urge you to think about cleaning up your plan. So let's talk about the first one, primary care. It serves as the member's first point of entry into the health system. And I think you just heard all the benefits of primary care, and we knew that's what we needed. We needed access to good primary care. The state already had a vendor in place for on-site health clinics. We have 5 health clinics serving 73% of the members. And it was only 3% of the plan costs. We did put more money into primary care, but we also shrunk the total plan cost. So it ended up being 5%, which was a good place to put our money. We refocused the health centers on primary health care only. There was no copay or coinsurance for the different services, so access was very easy for members. We negotiated 18% admin fee reduction with a bonus program for the administration. And we actually contracted for more health coaches and mid-level providers. But there are many, many other options that are available besides on-site health clinics. You've heard about DPC, you can do direct contracting, you've heard community-based solutions, but our first effort was to primary health care. Next slide. The biggest thing we did, and I like rolling out this little introduction here, as Josh mentioned, I work for NASHP, and we are looking at following the money through the healthcare system. And this is just a little preview of some work we're doing at NASHP. When it comes to hospital costs, it's important to realize that you, the employer, taxpayers, employees, consumers, and patients, you're the ones putting the money into the system. So I get very upset when I hear the large carriers call themselves payers. They're not the payer. You're the payer that's putting the money in the system that then goes to the hospital. And I took this position realizing that we were the payers. We were working with taxpayer money, and we are in control of where that money goes. And it's important that you flex that power. Next slide. So we took on an initiative to switch from the basic hospital pricing of discounted charge master. We wanted to base our reimbursements as a multiple of Medicare. So it was reference-based pricing, as it's usually called. But we wanted contracts with every single hospital so there'd be no balance billing to members. We ran our claims through a repricer. We found out what we were paying as a multiple of Medicare at the different hospitals. We targeted the 11 acute care hospitals that comprised 87% of our Montana hospital spend, with the goal of moving the high end down to the lower end, just narrowing that spread. We started this in April 2015, or excuse me, 2015, we immediately terminated our contract with a large BUCA plan. We did an RFP. We found a third-party administrator that would implement this for us, and this generated a lot of savings. So our strategy with the hospitals was definitely moving to Medicare reference-based pricing. But there are many, many other things that you can do as a plan. You can look at community-based solutions like Dave touched on. You can look at direct hospital contracting. We did reference-based pricing. You can look at narrow networks. In Montana, the governor's directive as a state health plan was not to go that direction because employees at all hospitals are taxpayers. You can look at shopping tools, price and quality. I did not find them as effective as the direct contracting and reference-based pricing. Hospital bill review, you can pull a lot of money back out of that system. We're starting to see what is called claims payment accuracy, and this is focused on the TPA and carrier. And we're seeing some very interesting results come out of that, of where the carrier may be keeping spread, just like you see in PBM contracts, where what the employer pays to the TPA or carrier is not necessarily the amount that ends up going to the particular provider. And we're starting to see more done in purchasing co-ops, bringing together several groups for steerage. But I think this is a big area to hit. Third, we hit PBM and pharmacy benefits. We analyzed our current contracts. We found spread, caps on rebates, a very ineffective appeals process, and high administrative fees. We contracted for a transparent pass-through pharmacy. We saved 23% of our plan spend that first year. We put in AGWIP. That is for retirees if you still carry them on your employee group plan, moves them into a Part D plan, and it saved quite a bit of money. And we actually paid less in administrative fees. But we added on a Montana solution for medication therapy management. We brought together a collaboration of the Montana Independent Pharmacists, the University Pharmacy School, similar to what Dave talked about in Community Solutions. They do direct member outreach for pharmacy drug adherence, chronic condition care, and coordination of therapies. And finally, the fourth area that we moved into, next slide, please, was to clean up the plan products. I named just a few of them here, but it's not surprising to walk into a plan that's been around for a while and see that they stacked vendors to try to find different products that might help. The first thing to do is really look at all these products. When I went to the state of Montana plan, there were 4 wellness products, 3 vendors, and they were stepping on each other. We immediately trimmed it down to only the wellness program that was offered through the on-site health clinics and 1 staff member to coordinate that. We saved $5.5 million immediately. So I urge you to look at some of the products which your consultants can help you with that might help your plan, but really look at, you might need to clean some of these out. Are you paying more for admin, or are you duplicating the services? Next slide. So my last thought I'd like to leave you with is a great quote. Problems become opportunities when the right people come together. Okay, now I'm going to show my age because this is a Robert Redford quote. I was going to use the Winston Churchill quote that says, crisis always leads to opportunities, but sometimes I'm seeing that misused lately. A couple of examples I'd like to throw out. Through NASHB, we were working with state employee health plans and supporting their efforts to do a lot of the things we've talked about today. And through those conversations, even through this COVID-19 situation, we've had reported to us that one state employee health plan who really digs into their claims, digs into their data, has found acupuncturist claims that were reimbursed for acupuncture treatment for COVID-19 immunity. Another one is seeing chiropractor telehealth reimbursed. So to me, you know, those are some opportunists, but for you, the employers and the consultants, this is a time we're looking at how money can come out of that health center and implementing some of the things you'll hear about today. The time is perfect. Thank you.
Okay, Adam, ask him about being on Jeopardy. Well, we've already embarrassed me about how I got blown out when I was on Jeopardy, so we better quickly move to the first next question here. Okay, so as we did before, we're going to have one question from COVID. Which OTC pill or supplement are nowhere near enough people taking in the age of COVID? Is it zinc, baby aspirin, famotidine, or quinine/tonic water? And Adam, if you want to ask any questions that might have come in.
Well, Al, I'm curious because Optum offers some health literacy Q&As, and I'm curious if that's anything like these questions.
You know, when we have customers or prospects who are asking us about Optum, we urge them to look at Optum because they make us look good. I mean, their idea of health literacy is they don't ask any question that can get any of their customers upset with them. So if they have a customer that makes zinc or baby aspirin or Pepsid or Schweppes, they're not going to ask the question. They're not going to have any question about it. So that really limits your questions when you have as many customers as they do. So survey says,
let's see here.
Zinc is the #1. So we'll come back and we'll figure out if the popular answer is the right answer. Next question. Which is true about regular long-term daily use of the most popular heartburn medications? Now, Zantac off the market. So these 3 things are growing quite quickly. A, you should take them on a daily basis for them to continue working. B, long-term use can lead to flatulence. C, there are suspected long-term adverse effects not listed on the label, like heart attacks, kidney problems, and fractures. Or D, all of the above. Anything else, Adam?
Yeah, Al, a lot of press on COVID and how health insurance renewals are going to skyrocket next year, but I think you have a different take on premiums.
Well, I think you saw it in Maryland's. I'm of the belief that it's well, it's not a belief. Expenses as a whole are way down, and you should be able to negotiate a much better deal with your buka. And if you can't, well, you've heard today from, and you will hear from speakers who are telling you just to get rid of the buka, because in fact, these things, they're making a ton of money right now. And if they give you a renewal that reflects what they think you're going to be next year, you should say, wait a sec, what do I get as a credit for this year when you didn't spend any money?
Love it. Let's see what the survey says.
Okay, so it looks like suspected long-term effects is the winner, just slightly ahead of all the above. So we'll come back to that one and see if the survey is right. And then the final one for this interim is Livongo achieves glucose testing rates of 2.6 times a day for non-insulin using diabetics. Which of the following groups support multiple blood checks daily? The American Academy of Family Physicians, the Society of General Internal Medicine, the Endocrine Society, or none of the above?
Al, what if the answers to your questions here are wrong?
Well, this is why I'm using them in the polling, is you could possibly, I mean, I really think these are right, but you could possibly argue them. But the ones that we're going to have in the actual contest are right and wrong answers, like I think most of these are. But for instance, that one about the supermarket, you know, you can't get sick from a salad bar. But if somebody wanted to challenge that someday when new data shows something else, they can.
I love it. Well, let's see here.
Okay, none of the above. So it looks like the survey people think that that Livongo, the largest diabetes vendor with a $4 billion market value, is doing things that no professional organization recommends. So let's see if that's right. And then I think I'm going to turn it back over to you to introduce Carter.
Al, thank you very much. I will actually take over that. I have the pleasure of introducing Carter Dredge from SSM Health. Carter is another one of those individuals really changing things at the provider level. He is the Chief Transformation Officer of SSM Health, and he is working on moving that from a traditional fee-for-service model to a value-based model, therefore payment situations where we all have a better outcome. He's previously worked in other divisions of the Catholic non-for-profit health system, as well as going through the pharmaceutical ranks. We are very delighted to have Carter join us today from St. Louis, Missouri. You're up, Carter Dredge.
Carter, you're still muted.
Can you hear me now?
Good.
Anybody? All right.
Good.
Great. Thank you very much. All right. So, you know, I work within like a large health system, but I am a little bit charged with massively transforming it from the inside out. I love to work with innovators like the people who are presenting on this, as well as the people on the conference call more broadly. And we're going to talk about the big thing we're going to talk about today from my perspective is the importance of business model innovation. This isn't just about a few services. This is about really engineering and a business model that creates what I would call a virtuous cycle of innovation. Next slide, please. When I start, I like this story. There's an individual named Florence Chadwick. She's a real hero of mine. And she's best known for being the first woman to swim the English Channel in both directions. And she set a world record both times. Next slide. But on a different occasion, she was swimming the Catalina Channel, which is, Catalina Island is a little bit off the coast of Southern California. And this picture is California out to Catalina Island. And the swim that she undertook was just about 21 miles, a long distance swim, pretty challenging to take on. And about less than a mile left. She swims 20 plus miles, less than a mile left, and she gets in the boat, gets out of the water, and doesn't finish the race. And all these people are like, why was it? Like, what happened? You take on water, you cramp up. What was it? Just too tired? And next slide. And she said, it was none of this. it was the fog. And she couldn't see. And when you can't see and you have no vision, the challenges become overwhelming. So like healthcare is complex, but let's not let the fog of what is out there stop us from what we got to do. We really got to clear the fog. So inside the health system, how do we make things more simple? Well, right out of the gate, so first several months on the job as the Chief Transformation Officer, everyone was trying to bring me up to speed on all these different operational initiatives. We're all great, valuable, trying to do things. But instead, just kind of clear the table and say, are we meeting the needs of our customers? Are our employers telling us that they're perfectly happy with everything? Are the cost trajectories in line? Are the quality without reproach? And is everyone can't even imagine of a better system? If the answers to those questions are not a universal yes, we have work to do. And we have work to do as a general industry, particularly in the incumbent space. So we went right after it and said, market specialization, like we really need to dial in like better, more clear primary care models. And Rashika talked about it, all these other presenters. We also universally agree that we've got to have clear, more direct, kind of just high touch, some technology-based options, but really about serving people in a different way that's not just about passing them on to a further higher cost setting. And so we went very aggressive on that. We don't have time to talk through all these. Second, in terms of risk and value, well, there are many systems that are fighting this movement to being accountable. They've always said no margin, no mission, but what about no outcome, no income? We are actually embracing that movement to risk and value. We have board-related goals that we need to drive this in a very significant way, because until our interests as a health system are more aligned with those who are actually spending the money in the community, we have too much tension, and that's not what we need. We need all effort pushing towards a lower cost, higher quality, more convenient and accessible model. And we can't have forces combating one another. We have to have them driving all in the same direction. Getting to risk and specializing your services is one thing, but we have to look at stepwise improvements. I'm a big believer as a transformationalist that I'm not just about incremental improvement, particularly when we're trying to talk about we have massive problems. How are we going to fix them? And so, like when I think about trying to improve like a revenue cycle process, instead of saying, oh, how do I get it 10% more efficient? I had to say, how do I not even need a revenue cycle process at all? How do we start to move to these fundamentally different ways of organizing the business to stepwise improvement of how we deliver the product? And then in the end, what I call value drivers. And then also, what are those things that cut across multiple settings, such as analytics, artificial intelligence, the gig economy, whatever term you want to use, in some of these different underlying structures that could permeate multiple areas. So when I think of virtual care, I don't think of it as a department rather than something to get intermingled with lots of different modalities. And I think Rashika really nailed it when he's like, it's not just about a discrete, urgent interaction. It's about extending access to specialized scarce resources to people who need that, when they need it, how they need it, et cetera, that are going to basically change the fundamental trajectory and ability to improve things fast across the board. For the sake of time, I won't go through all these, but I will give an example of what does a different business model look like. Next animation just for a second. So we set out, and just hold right there for a second, thank you. We had a goal to say, back when a lot of these drug prices went through the roof a couple years ago, and literally people were having a hard time even getting things like insulin, there were several of us that just got super angry. And we just said, this is not right. People need access to things. And it wasn't a cost shift, it was a market play, and it was just really frustrating. I had a friend of mine who's now the Chief Strategy Officer of Intermountain Healthcare in Salt Lake City. He and I were both working at Intermountain at the time. And he came up with an idea, and it's like, we should develop a not-for-profit generic drug company. I said, totally agree, let's figure it out. And with my expertise in a lot of things related to incentive design and business model creation, we set out and said, we need to figure out how to get people access to drugs they need as cheap as possible, as stable as possible, and as fast as possible. And we gave ourselves some conditions. We said, we can't rely on either public policy change or regulation. We love it in the long term. We're not giving up on it, but people are suffering, and they're suffering now, and we need to get on it. We also know there's big problems in breaking into some of these industries, because as soon as a new player comes in, large incumbents drop the price. They have massive economies of scale. They squeeze out new entrants, and before the entrants can get capitalized or get enough market share, they're squeezed out. So big time problem. You have to enter big, and you have to enter long. We also wanted to make sure that, again, even though typical drug development cycles take a long time, again, people are suffering now. What are we going to do about it? And then in the end, we're not going to be satisfied for simply making it go up at a slower rate. How do we drive significantly dramatic cost reductions overall? Next animation, please. And ultimately, we got a group of us together, and we formed a company called Civica. And I'm going to mention this because it talks about not just new services, but fundamentally new different business models. Next slide. So what is Civica? Civica is a pro-competitive, not-for-profit generic drug company. To start, we partnered with 7 health systems, some not-for-profit, some for-profit, and 3 kind of large-scale, big billionaire-type philanthropist groups. And we formed this company that would actually compete in the marketplace. A couple of things that we did were very unique. That second dot point is mentioned here is no equity interest. Nobody owns Civica. No shareholders. We basically capitalized the business in the expect that we would just basically, anything that was a form to get the capital running was a charitable gift. And after that, there were some, we provided some kind of lines of credit to be able to drive this thing going forward. Nobody owns the company. We set it up like a public utility. Because if we're trying to drive to lowest total cost, we don't want to house profits in the middleman of getting it there. Second, we realized that if we raised money from the people who buy the products today, but the lower the cost, the happier they would be. So we try to figure out how to set up businesses that instead of trying to make their margins higher, they try to make the cost and ultimately don't even need to have a margin other than perpetuity, break even, and sustainability lower. This derivative value concept of, for instance, we started with inpatient hospital drugs. So we raised money from hospital systems and philanthropies who their gift was the gift of cheaper drug access to the world. So in that case, the lower the price we can make the drug, everybody wins. Kind of an interesting concept. There'll be other areas in healthcare that I'd love to adopt this for, and it certainly will. We also did some unique contracting structures related to what's called a take or pay agreement, so that when all the other pricing things start to come down in predatory pricing, we take a long view, and we all stack hands as a group to say we're going to fix the problem. So that would be akin to, and it's an employer coalition to say we're all going to stick this out till we can get more sustainable prices. In this case, as setting up a not-for-profit generic drug company, we said once we go into the market, we're going to stay in sync so that when prices come down, we all just don't jump ship only to have prices go back up as soon as we leave. Next animation. We then, in terms of speed to impact, we worked with contract manufacturing organizations who had access to what are called ANDAs, abbreviated new drug applications, but they couldn't break into the market because they didn't have a market to really securely go into. When we started this, we raised $100 million. We had over 500 hospitals de novo from one, and we ultimately were able to basically provide a secure entry at the lowest cost possible for this type of offering. Next animation. And when we did it, as we acted with conscience, every single person gets the same price. Everybody. So that as we get bigger and therefore higher volume, lower cost, everybody gets the same price. It's a single transparent price for everybody. Whether you're one of the largest health systems in the country or you're a small health system in a small rural part of America, everyone gets the same price. We launched this in September of 2018, and before it was in January of 2020, so less than 18 months later, we had contracts with over 30% of the total hospital beds in the entire United States. And that's because it was just a fundamentally different business model. Civica is one example. We also can act as a conscience that we don't have to produce every drug. If someone starts to get a little bit greedy in the market, we basically say, okay, well, if it gets too egregious, we'll go in, use it in a not-for-profit basis, and then never leave. It's really just trying to think about innovation. So SSM Health was one of the key original organizations with that company, Civica, and many other notable organizations. I don't have time to name all of them today. We then also have already launched a second subsidiary of that company for retail medicines, partnering with insurers as long as they would adhere to the same principles of kind of lowest appropriate costs and transparent pricing for everybody. So moving up the value chain of making sure things are as affordable as possible, massively successful, and it's a good idea, but it was an even better good impact for people who are trying to get lower costs. We've done other things with Navitus Health Solutions, which is SSM's fully transparent PBM connection with some things Marilyn had mentioned related to Montana. We recently partnered with Costco to continue to, how do we continue to align us in the business community? We keep zero rebates. We pass everything on. There'll be other things we'll need to do in the future to make it better. We are big believers in the ability of direct primary care movements. We've launched several different companies with innovative companies to continue to make us as an incumbent go faster. We've worked with Paladina to launch a direct primary care model right in the core part of our market to drive those just efficiencies in primary care. We've contracted with other companies like Hypnosis to be able to provide very low cost access. We have done some other things with a company called Strive Health, with Walgreens, working with a partner called Navis, all about making healthcare more affordable and cheaper. Next slide. Summing it up with some of these summary points. Incumbent healthcare is too generic, too slow, too opaque, and too expensive. We have to do better. And the more that you can become sophisticated purchasers of those services, it keeps us on our A game to continue to drive high value in these types of areas. As a large innovative health system that is trying to very aggressively make things cheaper, higher quality, et cetera, we are looking for disruptive business models. We're not just looking for one-off services. We're looking for virtuous cycles of innovation, that the better we do it, the faster we can grow, and the better everybody is. We do believe risk is a critical alignment component, and we are actively seeking it, not shunning it. Next, we will make direct investments, form new companies, and partner with other progressive players, both employers, other providers of clinical services, different carriers of all sorts as they try to work as we go towards a better, lower cost, higher quality, and more transparent system. And in the end, it takes all of us as we work forward. So in conclusion, as you go to the next slide, next animation, it kind of zooms in here. It's all about vision. There's some excellent work, and you're hearing from all these people on here, that there are solutions. We just need to organize them. I am an optimist. I think we got this. It's not going to be easy, but it is absolutely possible, and there are already people leading the way. And I hope that we can just, in a small way, continue to make this more affordable in a big way for all of our employers, for our economy, and most of all for the people who really struggle with health challenges. I don't have time to give everything, but I will just leave you with this. My mother was paralyzed in a car accident when she was 15 that killed her mother, my grandmother, and she was homebound for over a decade. These are real issues. People need better ways to access these things, and we cannot allow people to suffer until we figure it out. So it's just a privilege to be with such wonderful innovators and such wonderful people across the country trying to solve these things. So thank you very, very much. Appreciate it.
Thank you, Carter. We're gonna do some Q&A at the end here. I know there'll be some good questions about that, but we'll get back to Al Lewis.
Okay, and here are the answers. This one, the popular winner was zinc, which, by the way, is not going to take away anybody's COVID or prevent it. The correct answer is baby aspirin. And if you go to the next slide, you'll see why. Baby aspirin used to be a big thing. They would say you took one a day and it would reduce your stroke and heart attack risk. widely recommended to adults over 40. And besides just a cheap little pill, what harm can it do? And this cartoon is from that era. Well, it turned out, next slide, that it could actually do some harm, that it could cause GI bleeding, and that if you did have an accident or something, the bleeds would get worse. This is a headline about low-dose aspirin can cause bleeding, so you can't just automatically take it. But this is 2020. The costs and the harms and the benefits, the risks and the benefits have changed. Strokes and heart attacks are more severe now because people delay going to the ER. It's possible that COVID is causing more strokes. People at high risk don't see their PCP, to the points that speakers made earlier, and learn if their risk is increased. But the good news is there are many fewer accidents, which means many fewer uncontrolled bleeds. So if you put that all together, more people should be taking baby aspirin. And you can look at rethinking the baby aspirin in the time of COVID to summarize the costs and benefits. Next slide. Okay, now this one, it was very close between C and D, all of the above and suspected long-term effects. The answer is suspected long-term effects not listed on the label. Folks, we can't blame Big Pharma for this. The label says stop taking this after X number of weeks and don't start again for X number of months. But people keep taking them anyway. So that takes out A as an answer and takes out D as an answer. As to B, well, I'm afraid you're just going to have to keep blaming the dog. Next. Okay, so there are some slides there you can look at later. You can look at these later, but they're all on links. The one about Livongo, testing everybody, the answer for the survey was correct. It's none of the above. What Livongo does and what they make tons of money doing is not supported. It's a little bit like the line from Casablanca, where Claude Rains says to Major Strasser, owing to the seriousness of this crime, I've instructed my men to round up twice the number of usual suspects. They are simply increasing something that does not need to be increased and probably should not be increased in order to show that they're doing something. And back to you, Josh.
Perfect. I will take it away, Al. I get the pleasure next of introducing Dutch Rojas. Dutch is one of the innovative providers that I ran into a few years ago. Blew my mind, couldn't understand what he did, and only after one of my clients ended up getting 2 knee replacements and didn't pay a dime for either of those surgeries did it sink into me the impact of the work he does. Dutch is an entrepreneur and the founder of Sano Surgery, Sano Surgery Exchange, and Everyone Health. He's dedicated to making medical treatments affordable and accessible around the globe. He's been featured on CNBC, The Wall Street Journal, HGTV, and he served in the U.S. Marine Corps. It is my pleasure to introduce Dutch Rojas today.
Man, I'm so excited. I told Adam before we started, I said, it's finally like, I feel like we're getting back to the world. I'm trying to see if, let's see if I can move this way. Yeah. I'm like, oh, I get to talk to advisors and brokers and I get to share what we're thinking. And this is wonderful. Adam, I don't mind if you do the slides. That would help me because I'm on my iPad. Okay. Yeah. Don't be afraid. Be prepared. I've been thinking about this a lot. So Bud and I, Mark and a couple other guys have been visiting with surgery centers. As you know, we partner with private practices around the country. And one of the things that we've been talking about is if you were born in the year 1900, like you would have seen about 200 million deaths from World War I, World War II, Vietnam, the Spanish flu. And so people are deathly afraid of what's going on today. And you ought to be afraid of COVID-19. But I think if you're prepared and you're ready to go, then we're going to help employers get to the place that they want to be, which is exactly what every speaker talked about. Of course, as you know, I think I despise the thought of Medicare for all. I despise it not because it's not wonderful in that people are covered. As Adam said at the beginning, healthcare is a reason that a lot of people go bankrupt. No, I despise it because I think it's selfish. I don't think the United States was designed to be a country just to help Americans. I think America is the light on the hill. It's the reason that I came to this country at 17. It's the reason that I became a citizen. For those of you that have never been to a swearing in, I was just at one recently in San Francisco, just before COVID started, and I got to see my best friend become a citizen, and it was quite an honor. I think that if you do work in Africa, which many of you have done, many of you have been on medical missions, if you've done work in Central America, South America, all through Asia, then I think what's wonderful is you are ready to help the free market build the right solution, which is what we're going to talk about today. Next, please. 3 primary areas I want to talk about. These are the areas that our companies are focused on. Today, we're mostly going to talk about direct to employer. We do have a marketplace app that's coming out, and then we have wholesale markets, which I'll talk about here in just a few minutes. The direct to employer piece, though, is most important. What is price transparency? A lot of government officials talk about it and hospitals talk about it. Price transparency is not making transparent a CPT code. When we talk about price transparency, and every single advisor on this call, as well as the hosts, understand that price transparency isn't, well, the facility fee for a colonoscopy at this GI center that's owned by Intermountain or whoever else, you know, it doesn't matter. There's a ton of health systems I don't like. So you get this price and it says $840. Well, yeah, that's price transparency, but it doesn't really answer the question. It doesn't help a health plan pay for anything. It just means that we're paying $840, and now what? So what is price transparency really? Price transparency really is making sure that every single person in the United States and those who have employee benefits know that the price is all-inclusive, consumable, and usable. In other words, it means you have an agreement to use the price. You didn't make one up out of your rear end and ask for a contract and hope and pray that they don't surprise bill you. No, it's an all-inclusive, usable price. Next slide, please. What are direct contracts? Direct contracts are really the heart of what we're talking about today. They are a contract between a buyer and seller. And for those of you who are familiar with Sano, you know that one of the services we offer is we help large corporations and now small and medium ones build their own narrow networks. And those are all based on, so we're not in the middle. There's no third-party interference, if you will. It's just employer A says, you know, we have employees in 4 states. We have 12,000 employees. They're located in Denver, Phoenix, Los Angeles, and San Francisco. Will you help us pay less for healthcare? So direct contracting is an agreement for a price, an all-in price between buyer and seller. Thank you, Adam. The direct-to-employer business is really deployed in 2 ways. The first one is a side-by-side, and the other one is a no network. And so here's what it means. If you have an ASO, you can add somebody like an Everyone Health, a Sano Surgery, a Zero Card, Surgery Plus, Bridge Health. You guys know who the players are. You can add those and augment their plan in addition to yours. So if you have an Aetna in a plan and you say, you know what, we're not sure about RVP, we're not sure we have enough bundle contracts in this location, what we're going to do is also have an ASO, and then we're going to augment that ASO with these bundled contracts. And so that's what a side-by-side looks like. The no networks is what we're seeing. Of course, every single speaker talked about it before me. The no network is what we're moving to. It is my goal to replace the carrier network and to do it without interference from third parties. So even ourselves. And so we're working on those solutions. We've now got oncology and transplant, maternity. And so we're bundling basically every type of service where we were just non-emergency. Now we're moving into inpatient and emergency services. What do self-funded employers need? This is probably my favorite slide because it's a point of contention for many people. My first goal in the world was not to reduce healthcare expenses. It is a result of the work we're doing. What I wanted to do was eliminate the carriers. And so the reason we talk about price is because private practice physicians, whether they're on-site, near-site clinics, whether they're DPC, virtual primary care, those people have access to a price. And if an employer can do a direct contract with them, then that solves the problem. And so it's not about just cutting expenses. It's about making sure people have a price. It's also about the elimination of surprise bills. If there's one thing in the world I hate, and I hate a lot of things, it's surprise bills. I want to make sure that employer-sponsored health plans and the rest of the world have price transparency first, so they know the price, because I think that's better than getting a bill later, even if it's for the same amount. I want to eliminate surprise bills, and I want to make sure that people get what they're paying for. Next one, please. How do we drive utilization? As those of you who have been with us for a long time, and I think I've been yapping in your ears for coming on a decade here soon, we've always had a hard time with utilization. So it's not that direct contracting didn't work. It's not that bundles didn't work. It's that we had a real challenge with how do we actually make it so that we're not redirecting any patients. I think redirecting patients is one of the most difficult goals and difficult things to do. Well, we solved that internally using asynchronous chat. Of course, many of you know I was highly influenced by Jay Parkinson. And so what we did was we created an engagement app so that literally anybody at any hour of the day can say, hey, my primary care doctor gave me an order for a CT of the abdomen and pelvis, and when can I get one? And when you can do that through chat, it engages people at a level that you cannot believe. All of a sudden, you're standing at an implementation meeting and you're saying, hey, just download this app from the Apple Store and from Google Play, and it's going to show you all your benefits, including the free option. And so using asynchronous chat really helps with that. Of course, there's no wait time. The app does all the scheduling, and it shows everybody what the no patient responsibilities options are in the 47 states that we cover. Next, please. Savings. This is probably one of the best slides for everyone on this call to keep and remember. The thing that this slide conveys is no matter what your benchmark is, and by the way, we work with you. Some have a 10% benchmark for whatever reason. Some have a 50, 60, 70% benchmark. Sonosurgery provides the contracts for the marketplace. Every single physician that we partner with doesn't have the greatest prices in your region. What we do is help you identify the ones that do meet your own standards so that you have a way. So the reason this slide's important, 50% of medical treatment expenses, right? And this is from utilization that we've seen over the last couple of years, is these small categories. People think, well, I got to save money on heart attacks and I got to save money on oncology and da da da. Look, if your benchmark is we want to save 45 to 50%, of that 45 to 50%, 50% comes from these items that are here on your slide. Orthopedics and spine, general surgery, gastroenterology. Oh, I know them by heart, it's okay. Physical therapy, radiology, and laboratory services. Laboratory services and radiology, physical therapy are the least utilized by the brokers and consultants we work with today for their employers, and they lead to a generous amount of savings. For those of you who know me for a long time, you know I harp on these blood tests, these blood lipid panels, which I think I pay $5.25 for in 7,800 locations, Quest and LabCorp around the country. The average company is paying somewhere near $65 for. Last week we did a utilization review for a large tech company. It was like they were paying $271. That was their mean price. So remember, 50% of the reduction in total expenses comes from just these small specialties. Thank you, Adam. What are the benefits to direct contracting? Obviously, they remove carrier interference, right? Like if there's any, like I don't like health systems, as you know, and I really loathe the carriers. So remember, the benefits are get rid of the carriers, we get 100% of claims, and we get back to the private practice patient relationship. And I can't harp on that enough. When you figure out, because a lot of you are doing this yourself, I'm so happy you are. When you do your own direct contracts, make sure you are working with private practice physicians. Yes, I got 3 minutes left. All right, let's go. Next one. Okay, next one. Because I got like 5 of these left, I think. Obviously, everybody knows the currencies of direct contracting. The flat fees are those without, flat fees are for radiology and labs. Bundled prices include a warranty. Percentage of Medicare is RBP contracts. So you kind of have that idea. Flat fee and bundled pricing structures, because these are the main pieces in any agreement. So if you go to somebody like a Keith Smith at Surgery Center of Oklahoma, and you're from Mustang, Oklahoma, which abuts Oklahoma City, you'll get a bunch of local services with the knee replacement. But if you're flying in, you're not going to get the PT. So that's really an essential piece of flat fees and bundled pricing. Let's see. Okay, so I want to go over this one, then I want to go over futures, and we can be done. The workflows of direct contracting. Listen, this is how these 5 ways are really how we figured out how to make direct contracting successful. So take my 17 or 18 years of experience and just kind of apply it to yourself. There's nothing better than on-site clinics. Zip, zero, nothing better. Direct primary care clinics, also fantastic. Virtual primary care, amazing. Our own platform is an engagement platform with physicians and nurses. On-site clinics make it really easy. On-site, which means like near site, shared site clinics. They allow your people to go see a physician physically, and then the physician just gives them an order on where to go. So they don't have to wonder about, do I have a down payment? Do I have a copay? Do I have a deductible? What do I have? No, there's no patient responsibility. Go here. Next slide, please. Let's go over the futures one, and then I'll be, yeah, perfect. Next one, please. Yeah, perfect. Thank you. Okay, so this will be my last slide. The reason this is important, forward surgery and surgery futures, these are obligations. For those of you running 500 life groups and longer, you need to be thinking about this. What we're seeing is, let's say you do a bundled price contract, direct contract with a private practice physician in your local area. We're seeing a 40 to 50% price reduction as compared to the BUCAs. What happens when you get forward surgery and surgery futures contracts is you're seeing another 10 to 25% reduction in price, right? So if you can do what's good for accountants like me is you can extend savings, and you can all of a sudden start seeing your pro forma, your budget get set in stone. So thank you very much for your time. We are all on the same page. If you have any questions, if you need anything at all, please make sure that you reach out. Appreciate the time. Thank you.
Thanks, Dutch. We're going to get back to Al. We promise this is the last time you have to hear him talk today.
What we've done is we do have a prize quiz, but we've set it to start after the session at 10 after the hour, so we don't cut into Adam's time or Q&A. Just to close here, we're going to show you why health literacy is already fixed to deal with Dave's thing. Most or a large chunk of this healthcare cost is useless. You don't need us to tell you that. Go to the next slide, please. And should you teach health literacy? Well, consider 3 questions. Number 1, is there an advantage to keeping employees ignorant? Number 2, is there any other expense item where all employees receive basically an unlimited budget? And number 3, is there any training in place on how to spend this unlimited budget? No, no, and no. Hence the business case for health literacy. Next slide. All right, I have a 30-second shameless plug, but I want to be respectful of the other speakers. So Quizify is cool. Next slide. Okay. So there are 3 sets of free things that you can start tomorrow. And in the interest of time, I'm only going to focus on the 2 that have been themes today. So you can go to quizify.com and you'll see Corona quizzes, and you can take those quizzes. You've already taken a couple of questions, and I might add missed them. So you might want to take a look at those quizzes and send them along. And so we're going to skip a couple, get right to the cheat sheets. We can skip this one. Get right to get right to the cheat sheets. Now, we've had a lot of talk today about primary care relationships, getting together with your primary care doctor. What you can get right from Quizify right now is you can actually download the questions to ask your doctor into your Apple Wallet. Okay, so use this link and we'll send it to you. And I won't even go over the questions, but imagine if you're a doctor and your patient actually comes prepared with questions. They don't have to write them down. They don't have to remember them. They just have to have their phone with them, and they can ask these questions. That will improve the doctor-patient relationship. I want to spend the plurality of I'm trying to keep it to 5 or 6 or 7 minutes, on surprise bills, because we've heard a lot about surprise bills today. The previous speaker obviously just said how much he hates it. I couldn't agree with you more. These are the stats on who's received them. And I have to tell you, I have a little firsthand experience, not having actually received one, but it turned out that I'm a limited partner in a private equity firm that makes surprise bills, whose business is surprise billing. I swear I had no idea. I had no idea. I didn't even know what a surprise bill was when I got into this firm. So I am profiting greatly from these things. So if you don't like me, get rid of surprise bills, okay? Don't let me do this. Now, how do you get rid of surprise bills? Well, it's actually shockingly easy. You heard about how to get rid of them for electives. What I'm going to talk about is how to get rid of them for emergencies, which today is, well, I don't know, about 80% of care. So I could just go back briefly because I just want to credit a couple people here. So I want to give some credit to all I did to solve surprise bills was take what I learned from David Contorno, who many of you know, and Marilyn Bartlett, who you just saw today, and Marty McCary, and they gave me the peanut butter and the chocolate, and I put it together into this surprise bill consent. Next slide. Okay, so just briefly on surprise billing and COVID, you're probably aware of this, but there's no patient share, which means no canary in the coal mine, no patient complaints about the bill. And that also means that doctors are just going to code COVID whenever they have the opportunity, because they're going to figure out that their patients will be happier if they don't have to pay. This is in various ERs and stuff. And here's what the surprise bills consent looks like. And like I say, it's downloadable. It is free on the link. You can get it 4 different ways. One, you can download the paper copies, and you can see it says, I consent to appropriate treatment and including applicable insurance payments to be responsible in total charges up to 2 times Medicare. So instead of getting billed 3, 5, 10 times Medicare when you go in for emergency care by these slimy ologists, these subspecialists whose practices have rolled up into these organizations that present their results to me every year when I sit in these annual meetings for this private equity firm and say how much money they're making by doing these things, you can put a stop to it. You can also write to me in newsflash. Send me a stamped envelope. I will send you cards that say that you can give to your employees to hand out. Or like this, that's my insurance card right there at Harvard Pilgrim. I actually taped this right onto my card, and I will send you some tape if you send me a stamped self-addressed envelope. Adam will send you the address. It works. It's been in the New York Times. And those of you who know Rachel Miner, she actually used it and reported on it in LinkedIn. And when she showed it to the ER person, the ER person said, good luck with that. But then after she explained it, the ER person said, yeah, that's pretty smart. So it works. Now, actually, we're going to play the trivia game a little bit later. It's going to go on at 10 after, and you will have a chance to win. And Josh and Adam will send you the link at 10 after, but I just don't want to take any more time out of anyone else's session. So I'm going to stop right here.
Perfect. Thanks, Al. So next up, and our final panelist today is Adam Russo. Adam has a firm that we all use called the FIA Group, a fantastic podcast, and he is a nationally renowned speaker, speaking to employer groups, physician groups, and self-funded employers. With no further ado, I want to turn it over to the great Adam Russo.
How's it going, everybody? Well, I'm in my basement. It's the first time I think that I've ever done a presentation in my basement at my house with a couple of my kids actually trying to peek through my glass door there to see what's going on. Hopefully they don't come in. Maybe you actually want them to fly in here and, you know, bother us a little bit. But it's great to be here. I'm actually very honored to be on this panel. You have amazing speakers today. Typically, I don't like to listen to all the speakers, but today, guys, I've learned a lot of amazing stuff. So again, thank you very much for the opportunity. We're talking about a recession-proof health plan. My entire desire for the past 10 years, I've owned FIA for 20, started in a basement, like I said, but for the past 10 years, all I've wanted to do was build the most amazing health plan for my employees. And people say, well, why? 2 reasons. 1, retention. If you care about your employees, and they're healthy and they appreciate the fact that you're taking care of them, they're less likely to leave. Second, recruitment. Now I know before, now it's all the COVID stuff. I mean, Massachusetts, where I'm at, I'm in Situate, Massachusetts, just south of Boston. We had an amazing economy right before all this happened. Now I think 25% of our workforce isn't working. But recruitment was huge for us in order to be able to actually encourage people to want to come work for my company in Branchville, Massachusetts. Adam, do you mind just going to the next slide? Thanks, appreciate that. So why do I have this? So those are my 4 kids. It is very challenging, to say the least, to be home. So, I'm in Massachusetts, like I said, we'll probably be the last state to get out of the quarantine. I see everyone else already, some people go to restaurants and all this fun stuff. I cut my own hair, to be honest with you. But the reason I have this slide is to show you what our plan is, the FIA plan at my company. Why? Because all the things I'm going to talk about today are the things that we've built over time in order to be able to offer and have what I believe is an amazing health plan. But the number one key thing that I wanted to make sure you got out of this today, if anything, is the fact that the number one thing we needed to do in order to make our health plan successful and to keep it high quality and low cost was to turn the actual patients, our employees, into consumers of healthcare for the first time. And that sounds easy. That sounds like, yeah, what do you mean? Most people do not look at healthcare as something, as a consumer in that realm. They look at their copay, their deductible. They don't look at the overall bill. But why do I have this here? In our company, a family plan, which I'm on, $472 a month. Blue Cross Blue Shield network. It's not reference-based pricing. It's Blue Cross network. No deductible, no copay for generics, no urgent care. People say, wow, well, maybe where you are, that's how it is. Well, look at what the Massachusetts average is. In Massachusetts, it's about $700. But in addition, you look at deductibles, $3,000 on average, which has grown 300% over the past 2 years. And the average copay in our state is $30 for generics in urgent care, not zero. Next slide, Adam. Thanks. Why do I bring this up? Very simply, it is important that your employees, that my employees understand and don't take for granted their actual health plan. So what do? We share with them what other plans look like. For example, Harvard University or American Airlines or any other large company, and say, listen, for your doctor or your urgent care, you have zero copay. You realize that at XYZ organization or American Airlines, they're paying $87 to go to urgent care. I actually think it might be cheaper just to pay cash. Anyways, you'll see what we have for generics, preferred brand, etc. Next slide, Adam. So what we have done is basically look at health consumerism. That's the number one focus. I know a couple folks mentioned direct primary care prior to me. It is the number one best decision we ever made, was to have a direct primary care physician, a team of physicians, about 4 miles from our office, that we offer to our employees free of charge. No copay, nothing. We pay the monthly bill. Roughly 75% of our employees use this direct primary care facility. Why? Once you go once, you realize it's nothing like any other situation you've ever went to see your primary care doctor at some health clinic or some health center. Total different world. We're talking about an hour-long consultation, 2-hour-long consultations. In the COVID world, you want to test? Go get one. You want to see him? Go see him. You want to have a video conference? Great. You want to do Zoom? Great. You want to just do whatever. It is the most rewarding thing that we've done, not only to lower the cost of healthcare, which has happened, but again, as a way to recruit and retain employees. Our direct primary care physicians become the gatekeepers for other things that might be needed. You need an MRI? Our doctors actually know our plan. So if you need an MRI, they're not sending you to some facility within a health network that's going to cost $4,000 from the MRI. They're going to send you to a freestanding clinic where that MRI is going to cost $500. All this information is very important. All these other things I'm going to talk about in more detail. So let's just go to the next slide, Adam. So why is this important? One of the key things that people don't do is incentivize their employees to care about the cost of care. But what I do see, reference-based pricing, whatever it might be, is the focus on cost, the price. Well, not everything that's cheap is good. to me, what's not really available in our industry, and most people don't really focus on it, but they should, is the quality, not of the facility as a whole, but the actual physicians, the actual surgeons within the facility. At Mass General, there's an A doctor, an A surgeon, but there's also a B, C, D, and maybe an F, a Dr. Death. Who knows? That to me is very important. By giving access to our employees of an app, they could go on the app, they could pick up the phone, they can call a specialist right away. And they can say, hey, I was told to see this particular surgeon for, a knee replacement surgery. They will tell you that surgeon is graded in B. There are other surgeons within the area that are higher ranked, that have done more procedures, less infections, et cetera, and at a lower cost. Why is that also important, the lower cost piece? Go to the next slide, Adam. Is because the key is incentivizing. What we do is on every single piece to try to brainwash these people to realize if I can lower the cost of our overall plan, it will actually lower the cost. It will actually make you money. You can make money saving money for the plan. On the second page of our plan document, that's literally what it says. Diapers and wipes. The Boston Globe did a story, that's one of our employees, and it says employers reward workers who shop around for healthcare. Like, to me, how is that a big story? Wow, they reward their workers. Are you kidding me? Everyone should. At the end of the day, what we've done is, listen, based on the slide before, we have all the quality metrics, the top facilities, the top surgeons, maternity, et cetera. And we go, listen, here's a list of 5. If you choose, again, it's a network. You can go to any hospital you want, any doctor you want, doesn't matter. But if you choose one of these 5, we'll pay for your diapers and wipes for a year. You can see right on the slide, 35 employees out of 35 pregnancies chose a facility from that list. So we have been able to save tens of thousands of dollars through this process. Next slide, Adam. This one's one of my favorites. Pharmaceuticals, drugs. The way we look at it is it's really hard to get organizations to switch PBMs. There's a lot of politics involved. The third-party administrator might have a reason to stick with one. You guys all know what I'm talking about. At the end of the day, what matters is employees and patients actually knowing that there might be a better alternative compared to the actual drug they were prescribed by their doctor at a lower price. Again, unlike my DPC doctor, Dr. Tremblay, who knows my plan, who knows what our copays are. Most doctors don't. I have one of my best friends is a doctor. I asked him, I'm like, do you have any idea what the drug costs that you're prescribing or what the copay may be for that person? He goes, no idea. So all we've done is we scrub the data once a month. And then if the company work identifies someone who is on Symbicort, and they will get a text sent to them, hey, FYI, there's this other drug available that will cost $1,092 over the course of a year versus $4,000, right? You don't have to do it, but maybe call your doctor or pharmacist and see if this might be an alternative drug for you. What we have seen is the number of our employees that have actually utilized this app, contacted these specialists, and then when they've gone back to their doctors, the doctors have usually, about 75% of the time, have said, yeah, you can make that switch. It saves them out-of-pocket costs, and it saves the plan money overall. Why is that important? Next slide. The key is incentives. Look at the bottom right here. For anything you're able to save, in any situation where you're able to save money for the plan, any situation, we give the employees 20% of those savings without limitation. There's no limit. Every single employee is focusing on the overall cost of care. Urgent care, like we said, waived. MRI, freestanding facilities, copays waived. Next slide. So, go back one. So what you see here is an actual situation that happened. We had a patient that stayed in the ER overnight, never actually had a private room. I don't know if this employee would have looked at this bill and saw, oh, private room, $14,695. I never had a private room. We were able to challenge it with the facility and saved $14,000 for the plan. And that employee got almost $3,000 based on the 20%. They share that information at the water cooler. They talk about it with everybody. This is spreads. It just spreads. Next slide, please. So what has happened? Based on the change of behavior of our employees, based on all these things, again, I've never had a situation where I've only been able to talk for 15 minutes. So I'm even talking faster than I normally do, so I apologize. What we were able to do for the first time this year was offer free healthcare for anybody who's been on our plan for 5 years, not just for the employee, but also for their spouse and also for all the dependents. It's free. We pay the contributions, all the expenses, 100%. Why do we do this? Again, retention. Do you have any idea how much it costs to actually recruit and train a new employee? The amount of money you're spending on that, it's tens of thousands. You're better off shifting and finding, when you find a good employee, get that employee to want to stay around. It encourages loyalty. And in addition to that, when people talk about this, from a recruiting standpoint, wait a second, you're telling me I don't have a deductible? Nope. If I'm on the plan for 5 years, it's free? Yes, it is, but there are some catches. Next slide. So this offer is contingent upon a couple major pieces. One is obviously plan membership, continuous, but the second is this workshop, cost containment workshop. We're not talking about enrollments where you learn about the plan, here's what's covered, here's what's not. We're talking about detailed instructions, one-on-one, where we talk about DPC, what your options are. We talk about preemptive consultation before you have any medical procedure. We offer our employees $100 just to talk to HR before they schedule a surgery to see what other options they may have. Next, price negotiated providers. Do we have any direct contracts? Let's talk to you about those. We talk about the prescription drugs. We talk about the quality and the vendors that we utilize. We talk about the diapers and wipes program. We discuss all the different options as it relates to urgent care. Now, we make sure people understand, utilize urgent care correctly. You know, if you cut your leg off, don't go to urgent care. But what we've noticed is we had 100% correct utilization of emergency rooms and urgent care based on our employees over the past 3 years. We talk about the claim audit review program. We talk about the fact that we actually give examples of employees getting checks. Some people got checks that are more than 2-3 months of their salary. And all these pieces are then checked off on, signed off on by the individual employees to make sure that they are aware of the top cost drivers for our plan, what facilities are the most expensive, what are options available to our employees, where they can get help. We talk about the trends not only in our state of Massachusetts, but nationally. We talk about all the new innovative programs that are out there. I mean, like I said, when it comes to the quality metrics, a lot of people will talk about the fact that they have, oh, this hospital is graded an A or this one's a B. But do you realize there are surgeons who may be at, Mass General on Monday, Tuesday, Wednesday, but because they like to golf, on Friday, they might be at some Cape Cod hospital. So you'll get the same high quality surgeon at a third of the price if you schedule your surgery on a Friday at that particular facility. These are all things we're doing to get our employees to become smarter, more educated, and become consumers of actual healthcare. It's very important by utilizing these cost and quality data metrics to make smart choices. Again, there's no stick. We're not forcing anyone to do anything, but we're advising them. If you choose to talk to us, if you choose to hear about the information, here are your options. Make the best choice for yourself and for your loved ones. Pretty simple. All right. Folks, you know where to follow me, all over LinkedIn, as well as the FIA group. We're everywhere. We're putting stuff. We've done over 1,000 COVID projects already, COVID-19. We're all over it. In addition, as most of you know, next slide, we have monthly webinars and podcasts that are done on a weekly basis that we would love for you guys to hear at any possible time. I guess my little timer is up, huh? Next slide. And we actually have a podcast later this month. Feel free to go to feedgroup.com, check out the media/webinars, and you can hear our old podcasts or actually listen to any of the new ones that we're doing, like the one we're having in a couple weeks. Guys, I truly appreciate the opportunity to speak to all of you today. And thank you very much. Appreciate it.
Adam, thank you for that presentation. All of our panelists, thank you very much. All of our panelists, thank you very much. For any of you that want to hang around for just a few minutes, we'll do a couple of questions on the live Q&A, and then we'll move over to the hashtag Recession Proof Health over on LinkedIn to put some additional Q&A from all of our panelists and presenters today.
Can you put that up in the chat section, Brett, so everybody
Yes.
can just link over to it?
Yep, will do.
While you're doing that, I just wanted to tell you guys and all of our panelists, thank y'all so much for your input today. The presentations were great. I've really enjoyed putting this together with you, Adam, and you, Brett, and all of the panelists. Rashika had to jump off to go to an appointment. But, you know, I'll kind of fire things off here. One of the recurring questions and themes that we saw when a lot of people talked about direct primary care, you use the language direct contracting, direct primary care. And it really is this strategy of taking the employer and directly connecting them with healthcare providers. One of the recurring questions that was coming up is talk a little bit, and this it applies to whoever wants to jump in on this, Dave or Adam, you guys have had some experience with direct contracting as well. Talk a little bit about the willingness from the provider side. And Marilyn, you can probably talk to this a lot when it comes to how much pushback did you get from hospitals and other providers when trying to negotiate these direct deals?
It's hi, it's Adam. Couple things to make note of. It really depends. I mean, it depends on the market, how many different facilities there may be. There are some, you know, facilities or hospitals that will say they want more business. They're looking for more business. It also depends on how quickly you can pay them, what the price point is, how large of a, you know, how much access you can give them to new potential patients. So all that comes into play. But I would say that most facilities that we deal with, and we negotiate cases every single day, direct contract every single day, most facilities under the right circumstances will want to make a deal. Now, how much they want you to actually share that information with others is a different story, but they definitely are willing to make a deal. Not everyone, but I would say most facilities are.
Marilyn, you have anything to add to that? I know you had a lot of experience negotiating with facilities in Montana. You want to add to what Adam had to say there?
Yeah, I think in Montana, we found 2 facilities right off the bat that were high quality and low cost, and one of them said, we knew this was coming at some point. And they were willing to negotiate, helped us build out the model. The larger health systems were less willing to move with us, and a couple of the really large independents. And I think what helped us is we had the data. We sent the data to sources that they trusted more, and we just kept with it. But shaking up the hospital reimbursement model and taking control, since we are the payers, was new to most of them, and it was not real easy. I think what we had on our side is that we were a public plan. We were the state of Montana public plan, taxpayer dollars. It was in the news about what the plan had been seen, and I think that greatly helped us.
As a follow-up to that, a specific question, were you required to use an in-state third-party administrator, or were you bound by any regulations or state provisions where you had to work with a TPA within Montana, or were you able to, when you left the BUCA model and went into an independent model, did you work with a TPA in-state or out-of-state?
We ended up choosing a TPA that is housed in-state, but the Montana law doesn't require that you choose a vendor in-state.
Great, thank you.
There was a question, this is for Adam Russo, about your health plan and kind of building off of these wins, you know, specific wins for employees. How do you share, you know, news across the office without violating HIPAA?
So again, we're not talking about specific employees in general, but usually the actual employees will talk about it themselves. So once they start talking about it in their cubicle or at the water cooler or the conference room, whatever it might be, I mean, if you actually listen to our podcast, half our podcasts are actual employees sharing their stories of how they actually were able to find a better physician at a lower cost, faster access. So to be honest, it's never been a concern for us because the information that we talk about is more in general. We say, hey, a particular, you know, we know of situations where the diapers and wipes, we don't have to tell people who's getting free diapers and wipes. I mean, they can literally see the person walking around the office, you know, 9 months pregnant, right? So that's not information that we're sharing. It's typically the employees that on their own just want to talk about it. And when they do, it spreads.
Mm-hmm.
Great. Another question that came in is for Dave. Dave, when you talk about community-based health plans, when we work with employers around the country, and obviously you're working through Health Rosetta with brokers and consultants all around the country, what do you see are the biggest challenges for employers to move to a community-based and unbundled plan design? There seems to be a big attachment to the BUCAs. And for those that don't understand that acronym, it's just an acronym for the largest insurance companies in America: Blue, United, Cigna, Aetna, and Humana. What do you see as the biggest, largest challenges for employers to leave that model and get into a different model?
I think it usually comes down to who they're getting advice from, that they have a trusted relationship that's not always well-deserved, but it's been there. There's general inertia and this concern that any change is going to be bad change, and you know, you'll hear about disruption as a concern, and I'm always quick to say, well, it sounds pretty darn disruptive to me to have 20 years of wage gains stolen from you, and that, you know, we're the undisputed world leaders in medical bill driven bankruptcy, and 70% of those people had insurance. So that doesn't sound like insurance to me. That sounds pretty disruptive. And so, you know, a lot of it's just a perception thing. There's kind of the Stockholm syndrome dynamic. Beyond that, you know, there's practical concerns that are very valid, and it's very easy for people to, you know, some brokers will get excited by some shiny object and don't really think about change management. When you look at, you know, major corporate initiatives like supply chain or, you know, sales and marketing automation, they'll typically think about change management, and then they'll do something here willy-nilly. So, you know, there's valid concerns. You got to be thoughtful on how you do it. But usually the biggest issue is just that first point, you know, that I have in that local. Just learn that it's very straightforward to leave the status quo behind.
Thank you.
Josh, I wanted to ask, for employers and maybe advisors, brokers that are new to the world of direct contracting, you more or less provide an easy button for them. So can you describe how working through you or a solution like yours allows employers to, you know, get to that point?
Yeah, I think we have a good solution. There's lots of others that everyone knows about already and that I love and support. And so I think, you know, one, we try to make sure we have good prices across the country for a bundled price, you know, all-inclusive consumable. And then two, I think we try to make sure that if you're using DPC, virtual primary care, or you're using any type of on-site shared site clinic, that they've got the right information through the platform via an API, right? So it's easily usable. I think one of the things that I thought about when Adam was talking a few minutes ago was, you know, one of the items that sets our direct contracting apart is that we have a day of surgery price. So if doctors want to get paid the day of surgery, we have a price for that. But they also have a 30-day price. They also have a 60-day price. And they also have a 90-day price. And then we have, you know, the futures contracts, which are in 5-year increments. So it's really dependent on, you know, who the payer is, as Marilyn points out. Like if it's a payer that says, well, we need 60 days, well, then sign up for the 60-day contract, man. Don't be easy. So I think we try to make it easy by saying, look, we're in 43 states. We cover pretty much everything. And, you know, you decide on the quality. What I loved about what Adam said about quality is I don't decide on quality. I provide all the aggregate information, such as you're an A doctor, B doctor, C doctor, D doctor. And your plan needs to make the decision. We work with your broker, whether it's a Health Rosetta broker or an advisor from another firm, and we help you understand what quality is. And we help you understand what the metrics are. I'm not going to do it for you. You have to decide for yourself what you want. Does that help?
Thanks.
One of the last questions that was another common theme throughout the discussions today is this seems to be a lot of more proactive, get in there, get your elbow, get your hands dirty type of work, much more proactive work. In the end, in a nutshell, is it worth the effort? Is it worth the work? Adam, I'll start with you. You're running a health plan like that. So tell us, is it worth all that extra proactive management.
100%. I mean, think about it. I mean, I have to go to my executive team. I have to go to my board and say, yep, I want to offer free healthcare for all employees that have been at the company for 5 years or more. That is not something you just easily could do, okay? The only way I was able to do it and get it passed was because they saw the trend. They saw how money we're spending less per employee. They saw the behaviors changing. And they also saw, wait a second, the amount of money we're actually spending to bring in new people and train these people compared to, hey, how do we keep good people around by offering a health plan that no one else can offer? As people get older, they start having families, they get married. Healthcare matters more to them. So yeah, sure, that 25-year-old kid that's there, you know, he'll go work downtown. He wants, you know, be able to go to bars and nightclubs after work, whatever. Maybe he's not the right fit. But if someone's 30, 35, and they have a growing family, and you're able to tell them, yeah, your daughter, that surgery she needs, it's covered and it's free. Where's that person going? That's called loyalty. That person is going to stay. When you can give them, like what Dutch was talking about, here's options. Here's the information we have regarding how much quality there is, what the grades are, what the infection rates are, etc. When you're able to share that information with people, they're grateful. I mean, more people spend more time looking at the quality of the TV in their living room than of the quality of the actual physician that's going to be doing a surgery on them. It's literally nuts. And so, yeah, it's definitely been worth it.
Marilyn, you look like you wanted to jump in there. Excellent answer. Love it.
Excellent, Adam.
And I'm done.
Absolutely, it's worth it. And I think, you know, for the state of Montana health plan, then you go 5 years with no added contributions or changes to the members out of pocket or their premium, no changes to what the state had to contribute. The plan right now has twice the amount of recommended reserves it should have. So it benefited the taxpayers, it benefited everyone, and employees have a better plan. They have primary care. And I would throw in, I didn't have a choice. I was the fiduciary of the plan. And my responsibility was to make sure every penny was spent for the member that benefit. I had to make sure the best benefits and the lowest cost were there. And employees at the state of Montana now get pay raises. They have on-site health centers. And I don't think I had a choice, but I would go after it again in a minute.
And the thing I would just add, I mean, all of that's true. Absolutely. I mean, I obviously wrote a book about it. Absolutely worth it. But there's no question it is more work. And this is something that I think we all have to be very focused in on, to take this from an artisanal corner of the industry to mainstream. You know, doing one of these unbundled plans is sort of like buying a car 100 years ago. You kind of had to be a mechanic. And over time, you didn't have to be a mechanic to own a car. And that's really where we're focused. I mean, that's ultimately why we built the technology platform we did, is we have to lower the barrier. So it's as easy to buy and implement one of these type of plans, these Health Rosetta type plans, as it is easy to buy these underperforming plans. So it's absolutely worth it, but we all need to work on standards and technology and norms to make it easier.
Could I just add one thing? Because there is one thing that's easy, and let's end on an easy, pressing the easy button. For goodness sake, just go to the Quizify website and hit emergency consents and give your employees the cards. Nobody should be paying a surprise bill for emergency care anymore. It's free to avoid it.
Amen. Thanks, Al. Well, want to wrap up. Thank all the panelists. I know we had to have a couple of our panelists run out. All of this is recorded. We're going to send out the slides. We're going to send out the recordings to everybody that registered if they couldn't stay for the whole thing. And just thank everybody for their time today. We really had a great time. Josh, Brett, anything else to add?
Thank you, Adam, for the idea. It's been a pleasure collaborating with you to put this all together, and to all the panelists, Dutch, Dave, Al, Marilyn, Adam, and Rushika had to bail out, but thank you guys so much, and Carter did too, but it's been great.
Thank you.
Thank you.
Thank you so much.
And most people stayed on.
And to most everyone that stayed on, joined in, we'll definitely put contact links to everyone that was on a panelist today. Please join together. We can't do this alone, and we really need your help to go ahead and fix the problem for everyone.
Thank you.